It's my absolute pleasure to introduce Deepak. Dr. Ravindran is a UK-based consultant in pain medicine and also a doctor of lifestyle medicine. And he has over 20 years of experience helping people overcome their pain. And he has a very long list of specialist qualifications. I was amazed when I looked at it, and I think I've concluded he's definitely a lifelong learner. He's widely recognized for his whole person, holistic, and trauma informed approach to treating chronic pain. And he's quite in demand as a speaker and educator. So we're very fortunate to have him this evening. He is the author of this fascinating book that we've been reading, The Pain-Free Mindset. I have 3 copies now, Deepak. You'll be pleased to hear in all formats. Um, when it
Thank
really
you.
helps both clinicians and patients to understand the complexity of chronic pain, I think, using the biopsychosocial framework. I recently listened to it on Audible when I was in the car, and your compassionate, caring voice really comes through. And Deepak also creates fantastic educational content on chronic pain on YouTube and other social media platforms where he is very active. I don't know how he finds the time. He's the host of an excellent podcast that we've been listening to called Pain Speak, where he interviews various thought leaders and people with lived experience. I would highly recommend it. Deepak is also on the advisory board of SIRPA, the Stress Illness Recovery Practitioners Association, who were the pioneers in the UK of mind-body medicine. And from my deep dive, I also know that he's a fellow runner and that he is a dad. So Deepak, we're so grateful and thank you so much for being here.
Thank you so much, Living Proof team and Sarah and everyone, Claire, today for having me. And yes, I love running, but right now I'm in the process of recovering from a ruptured Achilles. So actually, I've not been able to indulge in my stress busting favorite activity for the last 3 months now, because that's what happens when apparently the Achilles ruptures is I'm out of activity for the rest of the year. So it's been
Okay.
a difficult journey of a different kind this last few months.
Yes, I'm sure it gives you a even greater level of understanding what it's like to suffer with something that prevents you from doing what you love to do, which is what we're going to talk about. And Deepak, you're really working in the reality of doing this work within the NHS. And one of the things that's important to us in Living Proof is really raising the awareness in the UK and highlighting some of the important UK voices. And there's a lot of good work going on in the UK. And I know you're seeing many different patients with different types of pain in your practice. So, my first question is, the understanding of pain seems to have changed tremendously in the last couple of decades, I would say, and that we've transitioned from the thought, I'm in pain, so there must be something wrong with my body. Certainly, when I was in chronic pain for all those years, I 100% believed that it was a tissue issue, and I searched around the world for a solution to that. And then I came to learn that all pain is generated in the brain somehow. And that was an absolutely mind-blowing moment for me. Can you explain in layman's terms how this works? How is the brain involved in pain?
So thank you, first of all, Claire, for that question. And maybe I start, first of all, by just saying, what do we mean by pain these days? I would have to say that, like you, even though I did my medical school training first in India and then in the UK, we were not taught in medical school anything different than what the rest of society understands, that when you have pain, it must be because you've had some damage or something happening in the area where you experience the pain. So, therefore, it must be that part of the body. And even in people who experience headache or migraine, it was thought to be something either at a scalp level or a neck muscle level or a defined center in the brain, but nerves that can be gone after or blocked. So our whole understanding stayed on that front. And of course, what happens now in living proof, the way you've recovered, the way a lot of people in this conversation are now recovering, is all due to the neuroscience understanding in the last 10, 15 years. And put simply, we recognize that yes, the brain has to be a necessary and essential organ. And by brain, I do not mean necessarily what's there within the skull, but I would include the brain and the nervous system, the spinal cord that comes out from what's within the skull right down to our tailbone. So that part of the nervous system that lies between the spinal cord, between the bones and the vertebrae, and what lies in the skull together has the ability to interpret a wide variety of signals coming from every other part of the body and is then got to make a judgment about whether to protect or not. And to say that pain is an emergent, meaning that it is something that is the result of this set of signals that are coming to the nervous system looking at those signals, evaluating those signals, and saying, I think the decision is to protect. That is when the nervous system as a whole generates this sensation that we all identify as pain, as something that is extremely distressing, uncomfortable. And somebody, I think someone just pointed out to me, is the PAIN, pay attention that I need. So pain itself is a desire and a request of the nervous system to then pay attention to what is required and needed. And I think that's where we step out of the thing to say that the attention is not just to the part of the body, but can we just expand it out and actually say, what else could the nervous system be drawing attention to? Is it just a structure of the body, or is it something that is in the immediate adjacent to the body, that is on the skin, that could be in the room, within the house, in our local lane, in our society, and that is then expanded out. So this is the probably the most simplest way to explain how pain is now viewed as a protector, as a protective mechanism, as a result of a set of decisions made by the nervous system. It's a little, I don't know, convenient or inconvenient, depending on which way you want to take it, that most of this nervous system that makes the decision is located within the skull. And that has often led to this challenge of all of us understanding and always trying to frame it properly, compassionately, and sensitively. That when we say that the decision is happening in the brain, it doesn't mean we are making it up or it's in the head. But I try to move away from trying to focus on the brain or the head to say it's the entire nervous system, and the nervous system is in many parts, not just within the head, but also within the spinal cord, and all of that play a part.
Yeah. So let me see if I can understand that. I mean, I think I recovered through understanding basically that it wasn't a tissue problem. And I kind of identified so strongly with the personality types. Plus, I had spent 20 years excluding any other underlying issue. So I think I was primed for that. But I think I recovered without really understanding that I had a nervous system or what a nervous system was. But what you're describing, and there is an excellent review of what we've believed for hundreds of years about pain. This really turns it all on its head, doesn't it? To explain that what we're getting is not pain signals, that's outdated as a message, but rather warning signals that our brain and our whole nervous system is interpreting as danger. How do you help your patients understand that? Because as I say, it's quite a completely different to what we've understood about pain.
Absolutely. And I think that is the crux of the matter, and that is why it's challenging. But at the same time, I find it exciting. And to me, I feel like I can adopt the role of a detective when someone comes into the pain clinic and is with me. Because my curiosity is also in saying, okay, what are this person's beliefs? They are seeing me for the first time. They may have a view of what I might bring to the consultation today. They may not know me at all. They may not have done any of their homework on Google or whatever. So they'd just be coming there hoping that I'm a pain consultant who's going to give them some relief. And that is not therefore my role at that time to shatter their beliefs without providing an alternative framework that makes sense to them, that is appropriate and pitched at a level that they can understand, that they can move to. I believe, and I like this concept, which I found from another source when I was reading in the field of knowledge management, and that kind of how people make decisions when you don't have all the information. So this is something that I picked up when people are talking to CEOs and business leaders when they have to make decisions on millions of dollars, but they can't and they don't have the time to listen to 2 hour presentation and pitches from all the teams or the juniors and people on the ground, and what they get is just a snapshot of a few minutes or one high level presentation, and they've got to make a decision that's going to decide on a particular way the company is going to move. And in some ways, I saw the parallel that if you thought of our nervous system as the CEO, which has to make decisions based on a small amount of information or a snapshot of an information quickly, efficiently, without expending too much energy, then our nervous system is going to want to choose something that is going to be preferably safe, preferably convenient, preferably efficient, preferably fast. It's not going to really want to break too many things if it has got something that's already worked. If it ain't broke, you don't need to fix it. And that is, I found that model very applicable, and that is how the newer version of thinking about the nervous system, the predictive processing model comes through, is the nervous system makes these decisions quickly and has made some decisions to protect the person at a certain point of time. We know, sitting here, I might know that yes, that is a kind of pain that is not protective anymore, or at least it's not having any tissue damage. But the person sitting in front of me in the clinic doesn't know that. They are still running on narratives, and their CEO of their nervous system is still running on the narratives that it's probably a part of the body that's been affected, and this pain consultant is going to give me something or help something. So, a lot of my discussions in the first 15 to 20 minutes of the clinic is just in establishing, who am I talking to? Is this
Right.
person willing to consider that the nervous system could be responsible for creating these sensations, is responsible for amplifying their sensations? Are they going to believe that it is a part of the body that is definitely affected because of arthritis, because of some surgery, because of some scar, because of what they've been told by 10 other people on their long journeys before turning up to me? And if I find that they are actually in the second camp of where they feel it is definitely something in the body, then I do not spend that much time trying to convince them otherwise. Where I then find it useful is to just maybe make them aware of the gaps in their story, of any kind of slightly difficult to explain parts of why their pain feels worse when the scans are not showing anything, why their pain has got worse when there isn't a blood test to show. And if I can just let that discomfort stay, wherein they don't have an explanation, and could I give an explanation? And then signpost them to some of the resources where maybe they will get answers, then that is what I'm trying to get at in any consultation that I do these days is first spend, and yes, I have the luxury, I'm a consultant in a secondary care setting. Now, even when I do private practice, I still have 40 minutes. Sometimes I have an hour for some of the more complex consultations. So I have the luxury of time
Yeah.
that maybe my GP colleagues don't have. And I know a lot of you watching today who are from the UK do know the challenges of primary care. So I am blessed in that way that I have a little bit longer time, but I ensure therefore the first 10, 15 minutes is just hearing the narrative that comes through. And that's how I try to balance what I do and how I practice these days.
Yeah, yeah. What's really resonating with me, Deepak, and it makes me wonder what would happen if I'd met someone like you along my journey, is that you're obviously investing the time and that you have the time to find out who is in front of you and ask them about their life. And I expect they've done a lot of testing and trying other treatments before they are walking through your door. But my own theory is even before people can hear anything about the neuroscience of pain, they need to be heard and validated in their suffering before they could at all be curious, and creating that rapport with compassion sounds like that is at the root of where you're starting with the consultation.
Absolutely. And I think, and I'll be completely honest here, Claire. I think if you had met me seven years ago, 2016 or 17, I would have probably been like most of other pain consultants or pain specialists or orthopedic specialists, take your pick of body-based specialists, um, who might have just been saying, okay, you know what, you got pain. Yep, these are the structures, these are the things I could do, these are some medications, these are some injections, and I'll put you on the wait list. Good, my clinic's done in 20 minutes, 25 minutes, and I got time to grab a tea and come back for the next one. I would have been that, yes. But I was myself struggling with that dissonance of the fact that the procedures that I was doing, the medications that I was giving out, and the fact that around that time we started becoming aware of the challenges of opioid medication because of all the drama in the US. And so we realized, and I realized that, well, there is something I'm missing in my education when I did the pain fellowship, that something is not fully right. Something doesn't fully explain, and maybe there's some learning I've got to do. And I must say that the last 7 or 8 years, the principles of coaching, of motivational interviewing, of actually how to sit with the discomfort of me not knowing all the answers. I think there's a deep implicit teaching that comes through in medical school that somehow we must have a diagnosis to everything. We must have not just one diagnosis, we must have a differential diagnosis of 3 to 4 things, all of which can be evidenced by a yes or a no when you do a test or a scan. And so when you do have something that you cannot fully explain, most doctors struggle to sit with the discomfort and say, yep, I don't know why this is. Let's figure it out. By just listening to the story is not something we are taught in medical school. It's
Right.
something I've had to learn along the way to be comfortable with being uncomfortable. And I think that itself is a bit of a skill. But coming back to this part here about the coaching, I find that hugely as a pain coach now with Peak Health, I look at my consultations as okay, the first 5 to 10 minutes is about saying, okay, what are the things that brought you here? So that's all about listening, validating, understanding the narrative. And I tell my trainees as well, I use some of the principles of NLP, which is neuro linguistic programming, is actually here for the way somebody describes their symptoms, with the way somebody goes through life, the various challenges, the trials and tribulations that they have experienced. And I listen to the words, the languages, the sentence structure, because then when I can reflect it back to them, I try to then use a similar set of languages, words, sentence structure, because that's something I've been told enables at a sort of subconscious level the formation of rapport, the formation of being understood if you can mirror some of the actions and movements and words and thoughts. And so I work very hard in trying to get that rapport in the first 20, 25 minutes. That allows then me to set the stage for everything that happens. So my first consultation is often may not feel like something ground shaking, but it's about just getting those coaching principles, getting that rapport, exactly as you said, and that then becomes the bedrock for everything else that follows from then on.
Yeah, no, absolutely. It's really a moving thing to me to hear you say that. And I love your openness and honesty about what you didn't know that you didn't know, and your willingness to be uncomfortable and experience the discomfort, which is, in fact, a lot of what we learn when we start to engage with neuroplastic tools.
Probably two parts here. One is the focus on the nervous system. And might sound interesting, isn't it, that I say that when all I've talked about now is the nervous system. I'm going to be saying that by the next 10 years, we are going to be talking about the immune system as well. That we are going to be talking about the neuroimmune system. I myself now tend to use the word neuroimmune sensitization, and I'm trying to teach myself and ensure that I keep saying it more often. That is neuroimmune sensitization. That's the first part, that we will bring these two systems together. And this is like the CEO and the COO together. And that means you need someone to then actually CEO and all CEO and CFO, let's put it that way, because the implementation is the endocrine system. So I think that will be the third thing that will come through, and we'll be looking as these three big, the triumvirate will be the one dominating pain conversations in the next 10 years to come. That's where I
Mhm.
expect we will go as a system. The second part is how we then appreciate what we need to do about it. I think where we will think about the outdating part is right now we're still thinking about the concept of, is it the mind or is it the body? Is it the brain? Is it the body? I think there is already some talk about this in some few research circles, but we will probably mature to a point wherein we'll be using the words embodied, meaning that it's not just the nervous or the immune system, it's actually spread throughout the body, the whole of consciousness, as it were. And if we think of pain as an emergent output of our consciousness, of us as a human being, then embodied, meaning that the whole consciousness and therefore all experiences are present throughout the body at every level. It's going to be indistinguishable to actually say if you take pain out here, you shouldn't have it, because we still have to explain some irregularities in how we use this present structure. So I think let's all be that honest. Part there is, we know that the neuroplastic pain concept doesn't explain everything. We know that the nociceptive model doesn't explain everything, and it helps us because, at least to a certain extent, for the client, for the person in front of us, it helps make sense of 60, 80, 90% of it, but it doesn't explain the whole. And I think in the effort to try to explain the whole, we will have to move into embodied understanding of pain, embodied processing of pain. And that will mean we'll have to bring the ecosystem, because embodiment can only exist when you appreciate the context around the body. And that means the ecosystem will be front and center of any conversation we have in the next 10 years. So I think 10 years later, we will be having research that looks into saying what are the ways in which we can broadly reduce the embodied nature of chronic pain, persistent pain. And some of the tools we have today will be helpful in there, but hopefully we'll have newer tools that will also take into account the nervous, immune, and endocrine systems, joint involvement, and how do we regulate energy use. So I think that will be the part that will come through, is we will look at everything through the lens of saying what makes sense for us to be energy efficient, and what can we do as a human body to ensure that our energy utilization is stabilized, and any of these symptoms that we are experiencing, what we are right now calling neuroplastic symptoms, will be thought of as a disturbance from the equilibrium that we are all ought to have. And what should we do to restore that equilibrium by bringing our energies together? Now, that will expand our conversation into the various energies that right now sit in left field or woo-woo land. We'll probably have the science to bring it more into the mainstream. In my local NHS here, I helped set up the long COVID service for Berkshire, and I was the lead for that service for almost 4 years before I stepped out into primary care. And the long COVID service is still running, and I've done a fair bit of 3, 4 studies looking into various research around the brain fog, around fatigue management, around pain. Um, and the reality is that all of these symptoms can be viewed as neuroimmune disturbances. To a certain extent, there is the biological research that indicates that there are low grade, possibly inflammation like features happening because of the interaction of the immune system and the nervous system in the brain and in the spinal cord. So we have biological data slash MRI data, which seems to indicate that. But then we've also got this understanding from the work of Howard and David and everyone that the MRI images don't necessarily indicate the intensity of the symptoms people go through. And so a lot of the symptoms that has been mentioned in the chat that is happening in what we consider the neuroplastic space, so tinnitus, fatigue, pins and needles, paresthesia, what we call dysesthesia, altered sensations in different parts of the body that come and go, interoceptive, so symptoms or changes or signals that seem to come from inside the body, that is varying disturbances, pressure or tightness or bloating. All of these symptoms, you can come at it from both lens. From, if you adopt a slightly more biomedical lens, you can say that these are all features of dysautonomia. Your autonomic nervous system is not functioning appropriately. And if you approach it from a more mind-body approach, you would say that these are all threats that the nervous system is sensing, and these sensations are being interpreted by the nervous system in a way that decides what needs to be protected. And either way, for me, at one level below, if I have to say that whether we think of it as psychologically or whether we come at it from medical perspective, ultimately there has to be some change in chemical transmitters that occur at the level between the cells and the synapses and the microglia. These microglia are the name of the immune cells in the brain. So when I was talking about the nervous and immune system, this is what I meant. I meant that every interaction, every thought, every movement that we think of is an interaction at a molecular level between these two types of cells and the tiny chemicals they produce that decide ultimately what movement we'll make, what change we'll make, what behavior we will take on. And this is where right now the model, and I'll preface this by saying all models are wrong, but some models are more useful than others. And so if we come at it from there, the present model that's useful, that really helps at this point, is this model where the nervous system and the immune system can be thought of as one entity, which is saying, I'm receiving this signal, I'm receiving that signal. It's not pain, but it is a signal that I recognize as fatigue. It is a signal that I recognize as tinnitus. It is a signal that I recognize as deep pressure. What did I do the last time this sensation came? What did I decide? Do I need to tolerate it? Do I need to protect? Do I need to let it go and ignore it? Do I need to pay attention to it? And all of this is prefaced by it saying, Have I had this before? If I've never experienced this before, did my parents experience it? Did I see it on the TV? Did a lovely digital friend of mine have it? Did some influencer have it? Did someone I follow have it? And what did they do at that time? And that informs the decision making. If neither of these two processes are possible, it might be that do I have a distant memory of this happening to me at some point in my childhood? And does that mean, should I think of this sensation and act on it and be prepared to protect it? And ultimately, the output of the protection could be amplifying the existing signal and making the whole system pay attention to it. So, worsening fatigue, worsening tinnitus, worsening malaise, worsening dysesthesia or altered sensation, pins and needles, or pain. It doesn't matter. Ultimately, the output of the decision making by this neuroimmune entity is to say that I do not recognize, so I will want to pay more attention and ensure that I need some kind of resolution for this to happen. This is the present understanding of the neuroplastic approach to saying, okay, if I can then make you aware, the education element, that this is all part of the neuroimmune's decision making process, then are you prepared to say you don't need to pay that much attention? And some people are very receptive to it. And that's where I think the pain reprocessing therapy approaches or the neuroplastic retraining approaches makes a huge difference. And some people are fantastically improved. Some people take their time and need the support to be gradually coming. But this is where I think the slight introduction, when I talked to you about the energy, there's a very excellent researcher called Lisa Feldman Barrett in the US, and she's written a book called Seven and a Half Lessons of the Brain. And there's another excellent book as well, and a couple of fantastic lectures. I think the lectures I would recommend for your group to watch would be the Pufendorf lectures that she gave to the public last year. It's a set of 3 lectures that she did. But where I would say is, what about if the energy disturbance? What about if all these sensations, this tightness, this bloating, this fatigue, the pain, the cognitive disturbance, the brain fog, all of these are disturbances from the equilibrium. The CEO, the brain, and the nervous system and the endocrine system is constantly working to keep the body at a neutral energy requirement, the right amount of energy for the right amount of functions to happen as you go through life. But when any of these symptoms or altered equilibrium changes happen, that presence has a symptom. So the reaction is, does the nervous system say, what are the things I need to do to restore this back? Is it thirst? Do I restore swallowing difficulty? Do I restore this? Anything that brings it back to some equilibrium is what the nervous system is going to be trying. And that trials will sometimes overshoot and go too much, too less, too much, too less. And that's when people have the flare ups of various symptoms in an attempt for the nervous system and the immune system to bring it to a balance. And if the beliefs, the various narratives, the danger, all of these messages come through, that just takes the energy requirements even more over higher and lower. And so, how can our education actually restore this equilibrium and take out the highs and lows is another way we think pain education, brain retraining, neuroplastic stuff. What we probably are doing is allowing for the energy equilibrium to happen quicker. And that is when symptoms improve in some people. So observe that I'm not presenting that this is the way, but I think we have to be appreciative that these are the theories right now that people are coming by. These are the models by which we are working.
Deepak, I love that you mentioned the connection there between the nervous system and the immune system, because one of the things that I really struggled with was that I had inflammation showing on test results. So I had bladder pain, and my cystoscopy showed that inflammation, that damage in the bladder. And it was very difficult for me to understand, that is structural. I can see that on pictures, and I have consultants telling me about that and biopsies. how does that link to the nervous system and the neuroplastic approach? And it's only when I really understood the connection between the nervous system and the immune system and how inflammation is part of the stress response that I could really see that and get on board with the neuroplastic approach. So really appreciate you mentioning that. It was very helpful for me.
Thank you.
The questions that I wanted to ask you really relate a little bit to my own experience in pain medicine, because that will be kind of illustrative for others. So I spent a long time in pain medicine, both in the UK and the US, because I was kind of going back and forth between the two. And I have to say, everybody was incredibly compassionate towards me and tried their very best to find treatments that would help with this kind of relentless pain. But unfortunately, nothing that I was offered was particularly helpful. So it was medications with side effects. It was procedures, things like nerve blocks that didn't really provide any lasting relief. And then finally, I actually had a spinal stimulator implanted just to try to relieve some of that pain, because it was 24/7. It was honestly kind of ruining my life. And none of it was successful. The stimulator had to be removed. And so I'm just reflecting back on this and thinking, in that whole kind of experience, nobody actually talked to me about the role of the brain and the nervous system, and certainly didn't recommend any treatments that were based on the neuroplastic approach or that understanding of the nervous system. But this was a long time ago. It was over 10 years ago. So I would love to know what has changed today. So for a patient turning up in your clinic, in a pain clinic with pain that's not truly explained by tests and scans, what approaches might be recommended to them to help them with their pain?
Great question, Sarah. Really great. So where I would say is that we are right now in the middle of a transition in the UK healthcare system as far as chronic conditions like pain are managed. So there is going to be variation depending on where you are, which part of the country you are, what kind of GP care that you have. Across the board, if I have to take my most optimistic view, there are a number of GPs now who are not only trained in the neuroplastic approach, but actually there is a much wider group of people who are aware of all of this. So even if they have not trained in nociplastic pain or neuroplastic pain, and we'll come to that a little later, hopefully in discussing that, but there are a lot of GPs who are trained in it and talking about it to patients in primary care. There are GPs who are aware of it, not necessarily trained, but definitely more open to signposting people to a wide variety of non-drug, non-intervention approaches. There's a general appreciation of the fact that drugs are not good at all, and this has a board across primary and secondary care. There's a huge pressure on pharmacists and GPs to simply not dispense drugs, which means it's very unlikely that these days you're going to get someone just giving you tablet after tablet. They are almost mandated to provide you or not offer you tablets, but offer you some other kind of non-drug based referral. So usually a review to a social prescriber or to a health coach if they have one, or to a physiotherapist with the practice. And that's the other part of the system. There are huge numbers, certainly of physiotherapists, of manual therapists, of osteopaths, chiropractors, who are all trained or at least understanding that pain must be viewed differently. Business concerns and business models are part of how they all have to survive and pay for their mortgages and school fees apart. The science is definitely much more established, and a lot of primary care healthcare professionals are aware that there's a different way to manage it. And not everyone, I think many people are aware of the work of Living Proof, of certainly of Live Well with Pain, of Curable, of the work done by Lorimer Moseley and pain education, or Flippin' Pain. So I think the UK particularly is much more advanced. It's a smaller country than the US, but it's much more advanced, I think, in terms of awareness of these resources. Now, that's the very highly optimistic part. The slightly pessimistic part is that there are, for the reasons I mentioned above, there is that if your business and your model is entirely dependent on you carrying on something that the insurers are still paying for, that still keeps the the roof above your head, then there's little incentive to change those things. And that might mean that in some places you don't notice a big difference, or you don't get that information out there. And that's where I really value the work that organizations like yourself are doing, because I think we need that. That's the other part that has changed is 10 years ago, would not have known a patient who has recovered, or who's at least recovering, or who's made some change, come forward and interact with the mainstream establishment. Now, patient stories, lived experience, this is all essential parts of research, of mainstream voices. And this is fantastic because it means now we have a wide variety and stories that actually accompany the medical narrative. So there is a huge opportunity that I see here, but it's still not as uniform as we would like it to be.
Yeah, it's definitely encouraging to hear about those changes. And we see lots of pockets of work across the UK and people getting in touch with us about it, like a pain clinic that's being run by GPs that's mind body focused. And so many different pockets of work across the UK, but as you were saying, not necessarily joined up, and it can be a little bit of a postcode lottery what you get access to in your area. And I do think, patients in the UK, they face some immense challenges. It can be really difficult to get in to see your GP in the first place, to get a referral into a pain clinic, and then perhaps to connect with somebody who is more mind body informed, or of the neuroplastic approach, if that's a route that you would like to go down. So I just wanted to ask you, how do you think we can help patients in the UK to get the support that they need to find out more about the neuroscience and to really start implementing it within their lives?
Um, I will probably want you to repeat that question again, because I suddenly had a train of thought and I did not want to forget that. I just want to make all your members aware as well that, for example, at an NHS government level, there is this thing called Getting It Right First Time, GIRFT, which is a very important thing that a lot of NHS bodies have to pay attention to across secondary care, primary care, and community care. And there is a specific GIRFT, Getting It Right First Time model, that has been specifically looked at for chronic pain. And what that means is, over the last year and so, the clinical lead for the GIRFT is a colleague of mine called Helen Makins. She's from the Gloucester area, and she's actually managed to get one of her psychologists in the NHS service for her service interested and aware of pain reprocessing therapy, and actually look to offering that as a trial for the NHS patients in the secondary care service there. So she's the national clinical lead. The other GP who's on that part, who's an advisor for that setup, is in Newcastle, and their flipping pain and their models are there. So I'm hopeful that next year, when the report comes out from this GIRFT chronic pain group, they are probably going to highlight the work of a lot of the organization names that I've mentioned, including your name, Living Proof. So I expect that this then will be something that primary care commissioners of services and secondary care colleagues have to look at, have to be aware of, have to be cognizant of, and that will mean there will be a much more wider distribution of everything, the resources, everything that you're doing and putting out there. And that should be scaled up a little bit quicker. So I'm more optimistic that the 12-24 months will only get better for pain patients in different parts of the UK from where it is now. Coming back to what you said and what you've asked, if I remember right, is what can Living Proof do to engage and spread the message further? Would that be right?
So I was just thinking about a patient who perhaps can't easily get in to see their GP or get to the pain clinic or connect with a consultant who is mind body informed, or using the neuroplastic approach. What can they personally do to find out more about this approach and how they can actually start implementing it within their lives? Because it is quite a challenging environment sometimes in the NHS to even see somebody who might be able to help you.
Good point, Sarah. I don't have any easy answers there, but I think if right now, because not enough people, let's put it this way, the reality is that while there are lots of GPs and it's much more, offering the whole of the neuroplastic approaches, even PRT is difficult to do so in the NHS because right now PRT doesn't still come up on the NICE guidelines as something to be mentioned or offered. And that is a big challenge. Because that is there, a lot of established pain services or community services are hesitant to do something that right now isn't featured on the NICE guidelines. So while the guidelines are supposed to be guidelines, often they are tram lines. Nobody wants to cross them. And I think that's something is a challenge. So that means that right now, for someone wanting to explore neuroplastic approaches, they are having to look at paying private or look at least funding themselves initially or for some period of time. And I think the ways that I would probably suggest now is to look for in their area. And I think this is where the work that you're doing, Living Proof, I think SERPA has got a directory of practitioners who are then people can go to the website and see who's the person closest to them and get an appointment and see whether that kind of approach would work for them, would be suitable for them. I particularly, the one of the reasons why I sort of have gone a little bit more into this lifestyle medicine, trauma informed whole person approach that I do both privately on NHS is really that feeling that a lot of patients, when they need to move from the traditional model they've explained or been explained to this neuroplastic approach, and they are going through these various doubts in their head, is this right for me? Is this the one for me? They do need somebody who needs to be a guide, who needs to be appreciative of both of this ways of thinking, who can guide them and steer them towards the right way. And I think that's the kind of place I'm trying to occupy because I'm realizing that that's what people come to me and value from me is not that I'm going to present them with a cure, is that they have tiptoed. I get at least now one patient a month who's heard of Howard's episode with Rangan from before or recently, who's had these thoughts that, could their pain actually be because of nervous system sensitization? But they've got these doubts as in, who's going to help me? Where do I go? And I don't know where to go. So I'm coming to you because at least you seem to be knowledgeable about what's this and where to go. And that's what I'm finding. So they actually don't want any of the treatments from me. They just want to have the time to actually reflect on whatever's been happening in their life, make sense of what is neuroplastic and not neuroplastic, and then they decide, okay, you know what? I tell them these are the people, these are the places. Go away and think about it. If you do want my help, I have a team that can support you. But this is where I think we need to have more practitioners. We need to have more work from maybe Living Proof and maybe colleagues like myself who can offer that bridge. So think of it as there's this two parts of the hill. There's a deep valley in between, there's a narrow bridge across it, and you've got the neuroplastic approach on this side, but this big chasm to cross. Not enough people are sitting on the bridge there waiting for people from the other side to guide them across the bridge into the neuroplastic space, or actually say, nope, you've got a mix of both. So there are things that can be done or cannot be done. Right now, what we have is got a lot of people doing the neuroplastic or the nociplastic approach, and there's a lot of people doing the biomedical approach. But our patients and the people and the population do not know which way to turn because they have to make sense of their symptoms and their story and their narrative.
Yeah, absolutely. And I just want to say that part of our mission at Living Proof is to really make this science accessible to people. And, having gone through a decade of chronic pain and spent so much money on so many different treatments, and, particularly in the US when I was living there, I mean, huge amount of money. And you come out of that perhaps not with resources to invest in something else. So we're really, really keen to make this as accessible as possible to people. And there are so many fantastic resources. We have a page of our website that's devoted to them. And most of them are either free or low cost in terms of books, like Alan Gordon's The Way Out, Dr. Shubana's book, and also like online programs, apps. There's lots and lots on the market. But I do completely agree with you, Deepak, that sometimes it's just so helpful to have somebody kind of hold your hand, walk you through that, help you apply the science to your own situation and find the tools and techniques that will be most effective for you and support you through that. And that is obviously where coaches can be so incredibly helpful, but not always accessible to everybody. So it's really important that we have a plethora of different options available for people to learn the science and actually apply it within their own lives.
Absolutely. And I think that's where, isn't it, a huge number of lived experience recoveries like yourself, like other people have now taken it on in a way to almost pay it forward, how they've recovered. And I think that's a powerful way to do it, because any day I can only guide them so much, but actually to do the work, they are likely to believe someone who is like them, who has recovered, rather than somebody like me who's just saying this is the way to recover. That is not going to work, or you should do this, this, and this. If I have not walked in their shoes, then I really won't know what they've gone through.
Yeah, I have to say that, for me, like having a clinician tell me, yes, this is what could be going on in your body, after having so many other clinicians say something different, was really powerful. And that for me was Georgie Oldfield at SERPA. So she took me through the science, she applied it to my symptoms, she gave me that kind of, I guess, sense of approval that yes, I was onto something with this approach. And then I kind of went and applied it using lots of different resources myself. And I think combining a clinical kind of rubber stamping with recovery stories from people who've actually used this approach and actually recovered, they've reclaimed their lives. Those two things together were so powerful for me. And that's what we really try to do at Living Proof, is bring those expert voices and the lived experiences voices together to help people on their journeys. So I want to hand back to Jenny, because I'm really aware that there's lots of questions coming in the chat. So let's head into the second part of the Q&A, and thank you so much, Deepak. It's been an absolute pleasure talking to you. Thank you.